Welcome to this educational presentation on neurological red flags, clinical warning signs that demand timely recognition, careful assessment, and decisive action. In neurology, subtle delays can sometimes have major consequences because the brain and spinal cord have limited tolerance for evolving injury. The aim of this presentation is to highlight the warning signs that should immediately raise concern and prompt further investigation or intervention. Early identification can prevent permanent neurological disability and, in some situations, can save a patient's life. Next slide, please. Neurological red flags matter because they may be the first indication of a potentially life-threatening or function-threatening disorder. The challenge is that some of these presentations initially appear nonspecific. A headache, a brief episode of confusion, a seizure, or mild weakness may be easy to underestimate. But when the clinical pattern contains warning features, the cost of delay can be substantial. Conditions such as stroke, brain herniation, meningitis, intracranial hemorrhage, or spinal cord compression may progress rapidly. A structured assessment, combined with clinical vigilance and timely escalation, allows us to intervene while the opportunity for reversibility still exists. The key principle is simple. When the neurological picture is concerning, do not wait for absolute certainty before acting. Next slide, please. The sudden appearance of a focal neurological deficit is one of the most important emergencies in clinical medicine. Sudden unilateral weakness, facial asymmetry, arm drift, impaired grip, new speech disturbance, or abrupt visual symptoms should immediately raise concern for an acute vascular event. Loss of coordination, balance, or gait may indicate cerebellar or brainstem involvement, while aphasia or difficulty understanding language may reflect cortical dysfunction. Sudden monocular or binocular visual loss, diplopia, or a new visual field defect can also represent vascular pathology. A rapid bedside assessment using the FAST principle, face, arm, speech, and time, can help identify stroke quickly. The broader message is that time is brain. Emergency imaging, vascular assessment, and specialist review should not be delayed when acute stroke is suspected. Next slide, please. Not all neurological emergencies begin suddenly. Progressive deterioration over hours or days can be equally important. Increasing weakness, expanding sensory loss, worsening speech difficulties, or spreading motor deficits suggest an active pathological process rather than a stable neurological problem. Progressive decline may occur with an expanding hematoma, cerebral edema, evolving ischemia, or another process producing ongoing brain compromise. Changes in consciousness are particularly important. A patient who moves from confusion to drowsiness, then towards stupor, is demonstrating neurological deterioration that requires urgent reassessment. Serial examination is essential. Reduced responsiveness, increasing disorientation, loss of protective reflexes, or a fall in the Glasgow Coma Scale should never be dismissed. The goal is to identify a reversible cause before irreversible injury develops. Next slide, please. A first seizure, a major change in an established seizure pattern, or status epilepticus should all be treated as significant neurological red flags. A first-time seizure requires investigation for an underlying cause. Structural brain lesions, central nervous system infection, metabolic abnormalities, and toxic causes are among the possibilities that need to be considered. Brain imaging, EEG, and appropriate laboratory testing form part of the initial evaluation. Status epilepticus represents an even greater degree of urgency. Continuous seizure activity lasting more than 5 minutes, or recurrent seizures without recovery of consciousness, constitutes a medical emergency. Rapid treatment is required to reduce the risk of ongoing neurological injury. Even in patients with established epilepsy, a new seizure type, increased frequency, new semiology, or loss of previous treatment control should trigger reassessment rather than being accepted as routine fluctuation. Next slide, please. An acute change in mental status is not a diagnosis. It is a clinical warning sign. Confusion, disorientation, agitation, delirium, decreased responsiveness, or sudden behavioral change may reflect serious dysfunction of the brain or a systemic illness affecting the brain. The differential diagnosis is broad: hypoxia, hypercapnia, hypoglycemia, electrolyte abnormalities, intracranial hemorrhage, ischemic stroke, infection, drug toxicity, withdrawal, hypertensive encephalopathy, and sepsis can all present with altered cognition or consciousness. The immediate approach should therefore be systematic. Assess airway, breathing, circulation, vital signs, oxygenation, and bedside glucose while simultaneously performing a focused neurological examination. An acute change in cognition or consciousness should always be taken seriously until a reversible cause has been identified and treated. Next slide, please. Severe headache is common, but certain headache patterns should immediately change our level of concern. A thunderclap headache reaches maximal intensity within seconds to about 1 minute. This is a neurological emergency until proven otherwise. It may indicate subarachnoid hemorrhage, cerebral venous thrombosis, or another acute vascular process. Appropriate emergency investigation may include neuroimaging and, depending on the clinical situation, lumbar puncture. Another important warning sign is a headache that is distinctly different from the patient's usual pattern, different in severity, quality, location, or associated features. New headache in an older patient, headache associated with fever or neck stiffness, positional worsening, or accompanying focal neurological deficits should prompt urgent investigation. The important point is not to dismiss a headache simply because headache is a common symptom. The pattern and associated features determine the risk. Next slide, please. Raised intracranial pressure is a neurological emergency because continued elevation can compromise cerebral perfusion and eventually lead to herniation. Important warning signs include papilledema on fundoscopic examination, projectile vomiting, visual disturbance, and the physiological abnormalities associated with Cushing's triad, hypertension, bradycardia, and irregular respiration. These signs may appear late, so clinical deterioration should not be allowed to progress before escalation occurs. When increased intracranial pressure is suspected, the patient requires urgent assessment, neuroimaging where appropriate, and prompt involvement of the relevant neurological, neurosurgical, or critical care team. The priority is to recognize the pattern before irreversible secondary brain injury occurs. Next slide, please. Fever accompanied by neurological symptoms should immediately raise concern for infection of the central nervous system. Neck stiffness, photophobia, and fever may indicate meningeal irritation. Koenig's and Brudzinski's signs can support the diagnosis, although their absence does not exclude meningitis. A non-blanching petechial or purpuric rash is particularly concerning in the appropriate clinical context. Altered consciousness, seizures, or focal neurological deficits in a febrile patient should raise concern for encephalitis or more extensive central nervous system involvement. The essential principle is that treatment of suspected serious CNS infection is time-sensitive. Diagnostic investigations are important, but urgent therapy should not be unnecessarily delayed when clinical suspicion is high. Next slide, please. Neurological symptoms following trauma require careful attention, even when the original injury seems relatively minor. Loss of consciousness, confusion, amnesia, a fall in the Glasgow Coma Scale, unequal pupils, or failure to follow commands may indicate intracranial injury. Similarly, new weakness, speech difficulty, visual disturbance, or sensory loss after trauma should raise concern for injury to the brain, spinal cord, or peripheral nervous system. A particularly important warning sign is worsening over time. A patient who deteriorates over several hours after trauma may be developing an expanding intracranial hematoma, cerebral edema, or spinal cord compression. The practical message is clear. Neurological deterioration after trauma should prompt escalation and appropriate imaging rather than observation alone. Next slide, please. Back pain becomes a neurological emergency when it is accompanied by specific neurological deficits. Cauda equina syndrome is one of the most important conditions to recognize. Warning signs include severe or progressive back pain, bilateral leg weakness, sensory loss in the saddle or perineal region, loss of deep tendon reflexes, and especially bladder or bowel dysfunction. Urinary retention, incontinence, or loss of rectal tone are particularly concerning because they indicate significant compromise of the lumbosacral nerve roots. These findings require urgent MRI and immediate surgical assessment. The key principle is that back pain with new neurological deficits, especially saddle anesthesia or sphincter dysfunction, should be treated as an emergency until proven otherwise. Next slide, please. Neurological symptoms do not always originate from an isolated neurological disorder. Systemic features may reveal the broader cause. unexplained weight loss may suggest malignancy or chronic systemic disease. Immunocompromised patients are at increased risk of opportunistic infection. Fever with neurological symptoms may indicate infection or inflammation, while a history of malignancy should raise concern for metastatic disease or treatment-related complications. These systemic features substantially change the interpretation of an otherwise nonspecific neurological presentation. A headache, weakness, seizure, or cognitive change carries a different level of concern when accompanied by weight loss, immunosuppression, fever, or cancer history. The neurological examination should therefore always be interpreted within the context of the whole patient. Next slide, please. Once a neurological red flag has been identified, the next question is what to do immediately. Begin with a rapid neurological assessment, including level of consciousness, pupils, and motor function. Check vital signs and oxygen saturation. Establish intravenous access and obtain essential laboratory studies when appropriate. Review medications and recent changes because drugs may either cause or complicate neurological deterioration. If an intracranial process is suspected, urgent imaging should be arranged. Persistent focal deficits require urgent neurological review. Sudden focal deficit or coma may require emergency activation and stroke protocol. Declining consciousness requires attention to airway protection, and progressive neurological symptoms may justify monitored or intensive care management. Clear documentation of the time of onset is also essential. In neurological emergencies, chronology often determines both diagnosis and treatment eligibility. Next slide, please. Several principles bring all of these red flags together. First, when the neurological status of a patient is at risk, uncertainty should not become an excuse for delay. Escalate when the pattern is concerning. Second, remember that time matters. In conditions such as stroke, intracranial hypertension, meningitis, status epilepticus, and spinal cord compression, delays can translate directly into permanent neurological loss. Third, communicate clearly. Accurate documentation and effective handover are essential because neurological deterioration often evolves over time and may be recognized by comparing serial assessments. And finally, patient safety comes first. Act decisively, involve the appropriate team early, and respect the warning signs rather than minimizing them. Next slide, please. Thank you for watching. The central message of this presentation is that neurological red flags are not diagnoses in themselves. They are signals that something potentially serious may be developing. Recognizing them early, reassessing patients carefully, communicating clearly, and escalating appropriately can prevent avoidable neurological disability and save lives. When the neurological picture does not feel right, take the warning seriously and investigate promptly. This presentation is brought to you from Professor Mohammadi's Educational Archives.